Good morning, everyone. So excited and thrilled to have you all here for our kickoff launch for the Birth Equity Journey, the Penguin Maternal Equity Bundle, optimizing racial equity action across Massachusetts. As we progress across today, I'd love to continue to get more of you to continue to join us on this journey, as many of you have started on this journey with us with the opioid project, moving forward into the hemorrhage and hypertension projects, and now into the birth equity maternity bundle. That being said, with no further ado, we'll advance to the next slide. I want to celebrate and say Happy New Year or Shana Tova to those celebrating Rosh Hashanah. It was a unfortunate on our part that we used today as a date. We did not mean to dishonor the holiday, but do want to celebrate the Happy New Year with others. This recording for today's webinar will be posted on our website, so many of you who are unable to attend today will be able to receive the information regarding this particular bundle. Next slide. So welcome. So for those of you who are on, please type your name and your institution into the chat so that we can take roll. Keep yourselves muted if you don't mind when not speaking, and then feel free to type any questions into the chat for the webinar. This session is recorded. Again, will be posted on our website afterwards for CME and CEU credits. For many of you also on our website, there is the registration. So if your hospital has not begun registration or signed up to be a part of this bundle or to implement its components, please do so. We're ready and welcome with open arms for you to join as well. We'll go to the next slide. And review our objectives today. And then after the objectives, I'll turn it over to Dr. Jop. Today, we want to understand the importance or the why of addressing racial inequities in maternal health. We've been working to eliminate preventable causes of severe maternal morbidity, as well as to eliminate maternal mortality. Any maternal death is any maternal death too many. And so our goal is to eliminate all maternal deaths and eliminate the preventable causes of morbidity. We're going to learn today about the efforts from AWHONN to address birth equity through their Respectful Maternity Care Toolkit, as well as review the process of data collection and implementing our equity bundle, as it's known, using a quality improvement framework. As well, I say Dr. Vitek, Kaylee Vitek will also join us to give us the logistics of participation. This is a very exciting bundle for me and for many of us, and for those of you who have waited to do this work in particular. We've been doing this work and on this journey since 2016. We'll say more about that. But first, I'm going to turn it over to our founder of Penguin and our PI or principal investigator for all of the work that we do within this organization, and that is Dr. Fifi Jop, to give us a welcome and an understanding of the why we do this work. If you go to the next slide, Kaylee. And I will turn the microphone over. We'll hold here at the agenda slide, and I'll turn the microphone over to Dr. Jop.
Thank you so much, Dr. Meadows. Good afternoon, everyone, and welcome to today's webinar, which I believe is very timely in our state. Many of you know that Massachusetts is the second healthiest state in the country, with the lowest rates of residents without health outcomes at just 3%, and the highest concentration of primary care physicians in the country at 247 physicians for every 100,000 residents. This is coming out of the United Health Foundation report for 2022. Despite these opportunities, undeniable and unacceptable inequities in health outcomes exist and have persisted for decades. Data from the Massachusetts Pregnancy Risk Assessment Monitoring System, PRAMS, showed that the percentage of Black non-Hispanic who said that racism contributed to stress in their life ranged from 10.6% in 2015 to 28.4% in 2020, compared to a range of 1.3% to 3.4% among white non-Hispanic. As many of you know, there is a large body of literature that has documented racial ethnic inequities in reproductive health and racism as a fundamental cause of such inequities. A systematic review of 37 studies, mostly conducted in the US with physicians, found statistically significant evidence of racist beliefs, emotions, or practices among healthcare providers in relation to minority groups in 26 of these studies. In a study that examined preventability of maternal death, near miss, and severe morbidity, provider-related factors were mentioned for approximately 90% of the preventability in all three groups, while systems factors were cited in 33% to 47% of preventable events. And patient factors were only reported in 13% to 20% of preventable cases. The major preventability factor at any point in time in the morbidity and mortality continuum was inappropriate and incomplete management, including failure to diagnose, delays in diagnosis, poor communication, and inappropriate referrals. So it is a time for healthcare providers at all levels to acknowledge the historical legacy of racism and build a culture that centers equity to better understand the degree to which implicit bias, racism, and discrimination affect their Black patients. Governor Baker signed an act to reduce racial inequities in maternal health in 2021, which established a commission to investigate and study ways to reduce or eliminate racial inequities in maternal mortality and severe maternal morbidity in the Commonwealth of Massachusetts using evidence-based, best or promising practices, which aligns perfectly with the safety bundles we are going to talk about today. I hope you'll find today's webinar useful to your work. And with that, I'm going to turn it over to Dr. Kristen Price for her welcome remarks. Thank you and enjoy the webinar.
Thank you, Dr. Job. I just wanted to introduce myself because I think I may be a new face for some of you. So my name is Kristen Price, and I am the relatively new, I guess 6 months in or more, as the administrative director for PinQuin. And one of the roles that I've really been tasked with is helping PinQuin come up with a strategic plan for the next 1, 3, 5 years. And I will tell you that at the heart of this, equity sits in terms of all processes of our strategic planning. We recently met as a leadership group and revised our mission and vision statements. And the vision statement that we have arrived at is that PinQuin is the state leader in perinatal QI collaboration to ensure Massachusetts is a state where every birthing family receives the safe, high quality, and equitable care. And I'm super excited because I feel that the launch of this equity bundle is really at the heart of that. And so I just want to say welcome to everybody. Thank you so much for joining us. And this is just the beginning of a very exciting and productive road forward. Thank you.
Thank you so much, Dr. Jopp and Dr. Price. So for those of you who just joined, please put your name and your institution in the chat so we can better connect with you and have our attendance for today. The agenda is what remains on the screen. We've had our welcome and a wonderful call to action from Dr. Jopp. I'll begin to review some of the background data for this nation and state on why we're addressing maternal equity. And then we'll hear from our illustrious keynote, Rose Horton, on respectful maternity care and AWHONN's work to address birth equity. And then we'll move into logistics with Kaylee and some Q&A. So many of you, if you have questions, please don't hesitate to put your questions into the chat, and we'll get to those as well as more information as we close out the agenda for today at 1:30. We'll go to our next slide. I want to take a moment to thank and celebrate all the faces on this screen as well. We have a very robust experienced and supportive equity advisory group for Penquin. We're still growing. If anyone would like to be a part of our equity advisory group, please send a note to Kaylee Vitek at penquinadmin@penquinma.org. This is the group of folks who have been informing, advising, and engaging in what are the measures of the equity bundle as we move forward. We'll go to the next slide. All right, without further ado, next slide. So the conversation we're having today, and the conversation in the state of Massachusetts that we are so thrilled to move forward, is not just a conversation among us, the advisory group that I just showed pictures of, those of us on this webinar today. This is a national conversation that in 2020, the American College of OBGYN published a collective action addressing racism joint statement, where the professional organizations in the field of obstetrics and gynecology got together and wrote out one particular statement that all are committed to changing the culture of medicine, eliminating racism and racial inequities, and that leads to disparate health outcomes, while promoting health equity in women's healthcare and women's health. And that's really important because this is a growing movement, an area where race is not the culprit, but racism, and addressing what we have within our systems, particularly structural racism, to move in the right direction and improve the experiences and outcomes for everyone. We'll go to the next slide. Next slide. So we'll start with looking at maternal death. In this country, many of you are aware, many of the Penquin webinars that we've hosted over the years, we've continued to show this data. And this slide captures this data over the course of years. If you look from left to right, in 2018, the number of deaths in our country per 100,000 live births was reported at 17.4, and that was astounding. The next year, for 2019, we saw that number go up to 20.1, that's 754 deaths. And then the next year, in 2022, this past February, the CDC reported 23.8 as our rate, that's 861 deaths among 3.6 million live births. With that, we understand that the work is still yet to be done, that we want to eliminate the causes of maternal death, we want to address maternal death, and we want to reverse these trends. You can keep it there, Kaylee, it's fine. There are persistent and stark disparities. We know for that most recent data, so this is all data from the 2022 published report on 2020 outcomes, that for non-Hispanic white, the overall rate is 19.1, still now higher than it has been as reported in 2018. For Hispanic, it was 18.2, and then for non-Hispanic Black, a very astounding 55.3. These numbers show the stark and persistent disparities that we've experienced in this country, particularly for those who are Black and Native American. Next slide. We have, as Dr. Jot mentioned, a new report from the CDC looking at the Maternal Mortality Review Committee outcomes of 36 states. And it has been determined in reviewing that data between 2017 and 2019 that 80%, 4 in 5 pregnancies, pregnancy-related deaths could have been prevented, 80% preventable. And if you look to the right of the screen, here are those leading causes of pregnancy-related deaths. Mental health, which includes suicide and overdose related to substance use disorder. Second being hemorrhage. Third, cardiac conditions, followed by infection, thromboembolism, cardiomyopathy, and then hypertensive disorders. In the state of Massachusetts, we know those leading causes were related to overdose, related to opioid use disorder, hence why we began our first bundle with opioid use disorder. And the other 2 leading causes, as well as 2 leading areas of the disparity, included hemorrhage and hypertensive disorders. We'll go to our next slide. And that explains why we include hemorrhage and severe hypertension as our 2 bundles. As we look at our Massachusetts data, so zooming out of the United States, we looked at death data and morbidity data. As we're moving into morbidity data, we're looking in our own state, in our own backyard. Here we're looking at the statewide severe maternal morbidity rates. That's called the SMM20, those 20 diagnoses codes that allow us to determine the morbidity rates. This shows in our state, if you look at the blue line at top, that shows the rate for Black non-Hispanic. Below that in orange, Hispanic, and then red is all other, and then the turquoise line at the very bottom is for white. This shows us that even in the state of Massachusetts, to Dr. Jop's earliest point in our remarks as to the why, we are one of the healthiest states. We continue to show a racial disparity in our outcomes. So for those who are Black, non-Hispanic in the state of Massachusetts, their rates of severe maternal morbidity for all reasons are double that of others in our state. Next slide. This also looks at the same information of SMM21, that 21st diagnosis includes blood transfusions. And as well, we see not only do we have a disparity that's been persistent, we also show that those rates and those numbers are rising. So we continue to see an increase in the number of those experiencing severe maternal morbidity, and that severe illness, those near-death experiences on labor and delivery for our citizens and for the women that are giving birth in our state. Next slide. So what are some of our solutions? As Penguin, as a quality improvement organization, Dr. Price read our mission statement in that we want to be the safest, the perinatal QI organization that supports all hospital teams across Massachusetts giving safe, high quality, equitable care. To do that, if you go to the next slide, we implement safety bundles, and we know that that works. Our action is systems-based improvement. This slide shows to your left what I call a famous graphic, because many people have seen this graphic over the years. This is information on the maternal mortality. So again, death, maternal mortality rate for California and the United States. And between 1999 and 2013, the red line, which is the US, showed that continued rise. What we know to be what's happening in the United States is rising rates of maternal death, and we need to reverse those trends. What's shown next to that in the blue line is California's rate, showing that once implementation of maternal safety bundles began, we saw a decrease in the rates of maternal deaths in the state of California. That was really exciting information. When you fast forward to what was most recently published in April of 2022, Dr. Davidson in Texas and her team wanted to further address not just maternal death, but those precursors to maternal death which would be severe maternal morbidity. They addressed severe maternal morbidity in their hospital system and implemented the AIM maternal obstetric hemorrhage bundle. And in doing so, they were able to see not only the rates of maternal morbidity, so illness, decrease, they also were able to show the race and ethnicity gap that exists there begin to close as well. And what they did in implementing their bundle is not just implement the components of the bundle, but also work with their teams to disaggregate their data by race and ethnicity so that teams could really start to understand those that were most impacted and put in place through their driver diagrams and their change concepts, those actions and activities that would really improve the outcomes for others. And they've seen success. We know this can be successful. Systems-based improvements show success. Let's go to the next slide. So in the state of Massachusetts, what have we done to drive these initiatives? So we joined AIM in 2018. AIM is the National Data-Driven Maternal Safety and QI initiative that focuses on implementation of maternal safety bundles to improve maternal care, safety, reduce morbidity, and eliminate those preventable episodes of maternal morbidity and mortality. Based on our data in the state of Massachusetts and where we had the greatest difficulty and the greatest challenge, we implemented obstetric care for women with opioid use disorder, that first bundle. And we want to congratulate and thank all of our teams that participated in those bundle and that bundle implementation and those activities between June and September of this year. We also began to implement the optimizing management for obstetric hemorrhage bundle over a very short 6-month period between June and December. And part of the reason that was short was in that it was also with the fact that many hospitals were implementing those components in response to the new Joint Commission requirements. That goes, the same goes for optimizing management of severe hypertension in pregnancy. We did that in 6 months between January and June for this very same reason that we knew many teams were working on that. As we move into the year-long optimizing maternal equity across Massachusetts, or the equity bundle, what you'll see are the process measures of the clinical work that are important for the obstetric hemorrhage bundle, as well as the severe hypertension pregnancy bundle. They are still there. So we'll continue to support the teams in doing the work of both of those bundles in order to address maternal equity. Next slide. So equality and equity. You've heard this, many of you, over the years of us discussing our journey in Penguin. I want to say, us implementing safety bundles is a version of equality, giving everyone the same things. But the assumption that everyone benefits from the same or equal supports is a false assumption, because we can see from this graphic provided by the Institute for Perinatal Quality Improvement, those on the right, those on the left, those birthing individuals standing on the same box are not all able to fully fulfill their potential for the greatest health and their greatest health experiences. When we apply an equity lens, we give others what they need, the support they need to attain their full health potential. And what's wonderful about this graphic, and many of you have learned who participated in the Speak Up program, that in the version on the left, you see the extra boxes. This is not a zero-sum game. This is what we do every day in our clinical work and our clinical practice by addressing the needs of specific individuals, as well as creating a foundation of infrastructure and support within our own clinical systems and hospital L&D units to offer what everyone needs, while giving specific individuals what they need as well. When we implement obstetric hemorrhage risk assessment, when we implement QBL, those are ways to offer both equality and equity to understand what the needs of individuals are. Next slide. So a path forward and a path toward equity. Many of you have also heard this comment as well. It is important to know, though the numbers for maternal morbidity and mortality are highest for Black non-Hispanic women, Black women suffer preventable morbidity and mortality at greater rates, even when there's no increased physiologic or risk or predisposition for Black women. It's important to say, because many of us those who may have trained with me, many of us who trained years ago, it was often a phrase said and used that, quote unquote, this is just what happens to Black women. And that's not the case. It is true that Black women do not have an increased physiologic risk or predisposition. And though they may not bleed more, they are more likely to die from an obstetric hemorrhage. And with that information, we know that there are keys toward moving forward. I participated with Dr. Deborah Bingham in the IHI Better Maternal Outcomes work to address preventable morbidity and mortality. And in the hypertension and hemorrhage sprint, some of the key actions that came from that work were to listen to patients. And that brings us to our discussion around respectful maternity care with Rose Horton. We also worked on recognizing hypertension and notifying providers, recognizing hemorrhage via risk screening and measurement rather than estimation of blood loss, and then reducing time to treat. So eliminating that denial and delay in care while educating patients and families respectfully allows us to see those outcomes that we saw in the earlier slide, that we could not only reduce morbidity and mortality, but also begin to close the gap. Next slide. So this is to show everyone who participated again. Thank you. Thank you for those who participated in the Speak Up program. Our Speak Up Against Racism action pathway allows us to develop and train champions to have the tools so that when we are on our L&D units and we're working with patients and families, we can support ourselves, our patients, and our colleagues in doing this work to truly move forward, dismantling those structures and processes that reinforce racism and bias on our labor units and in the work that we do, and also have some accountability by tracking the data and processes that we're wanting to change and improve to address inequities. Next slide. This is my closing slide as I turn it over to Rose Horton. I just want to show that we've been doing this work toward health equity together for a number of years. Many of you have been with us as we established Penguin as an equity-based organization in 2016. Many of you have been on the webinars and viewed the slides that we've shown as we talked about the Massachusetts Department of Public Health as it moved into shifting cultures toward equity over the years, particularly in 2018 with raising awareness. We joined AIM in the late 2018 and launched in 2019 to again raise awareness and apply this equity lens and focus to the work that we do. In 2020, we began to build our equity culture even further when we distributed our first set of SMM reports to all of the facilities across Massachusetts. Now we've met with all 40 hospital teams to review SMM data by race and ethnicity so that folks could begin to understand where there may be inequities in their own systems, and that the problem is not external, but the problem exists within all of our institutions. And to address these issues, and I use the word problem, I prefer to use the word challenge actually, as we work together to overcome these challenges, we wanted to give everyone the language and understanding by beginning that racism and bias upstandard training that we did with teams, not only with Speak Up Against Racism, but also with the trauma-informed care trainings. We then have paired that data and that action that we've taken to provide those SMM reports with work that we know is important, these safety bundles, so driving our equity action. So we've had our racial equity trainings continue. We also worked with the Massachusetts maternal legislation to work on addressing equity as well. And then we've also developed this bundle together as a team. And now we're going to continue to drive our equity action forward through QI and through implementation of this bundle together. And so without further ado, we'll go to the next slide. I'm very excited to introduce our keynote, Rose Horton, who serves as the Executive Director of the Women and Infant Services at Emory Decatur Hospital. She as well is a very well-regarded, awarded nurse who has served as the president of AWHONN, and she also currently serves on the President Joe Biden's task force for Black maternal health as part of their stakeholders group. So we are very excited to hear about what Rose Horton and her team at AWHONN and her team in Emory have worked on to also address maternal equity. And so I'd like to turn it over to you, Rose. Thank you for joining us and thank you for being here.
Thank you so much, team, and thank you, Dr. Meadows, for the invitation, and to my colleagues who reached out to me. I am already inspired and full based on the work that you're doing in Massachusetts. It's always so great to hear that people are really engaged in making substantive change along with the incremental change. So my hat's off, and I am so inspired. So thank you for your work. Let's go to the next slide. A couple of slides are going to be just informational. So all of this, and most of this information is copyrighted by AWHONN. And in the next slide, what you'll see is that we were very fortunate to have received support from Huggies for all of this work centered around respectful maternity care. So if you know any folks from Huggies, thank them. The next slide is just speaking about my disclosure. I have nothing to disclose, so we'll go ahead and get started with objectives. So the respectful maternity care approach is really designed to help reduce disparities and maternal morbidity and mortality, to support families and as they prepare for birth. So the RMC toolkit will help reduce disrespectful care and support the fundamental rights of women, birthing people, newborns, and families, promote equitable care, access, and also recognize and honor the unique needs and preferences of all women and birthing people. We think that's important. So in creating this work, in the next slide, most of you probably already know this, but WHO, under their safe maternal and newborn care, one of their goals for 2021, 2022, and I think this is going to extend, I think, through 2030. So if you look at goal number 3, to promote respectful care for safe childbirth, all of the goals are pretty impactful and significant, and really speaks to the work that PINQUIN is doing as well. But I'm going to focus on goal number 3. I love goal number 1 as well. We need to talk about that. What practices do we put in place in healthcare that are harmful to women? That's a whole nother conference. We'll save that for another day. So as we decided to do this work at AWHONN, there were a couple of things that really informed the work. And I think Dr. Job with her comments to start really touch on many of those. But in the next slide, you'll see something that I usually reference, and it's the Giving Voice to Mother study. Dr. Vidam and her colleagues in her work said that global health experts agree that how people are treated during childbirth can affect the health and the well-being of the mom or the birthing person, the child or the baby, and the family, AKA the entire community, right? So the care that we render has an impact on the entire community. So What kind of care are we rendering? And in the next slide, it'll show you the results from the survey. I think 20,000 surveys were sent out, and 2,138 women in the United States and in Canada responded. And this is their response. So 1 in 6 women talked about mistreatment during childbirth. 1 in 6. So I think it's sobering. What is the mistreatment that they experience? You'll see it on the slide. Being shouted and scolded at. I've seen that in my care. Having healthcare providers really wait before responding to their request. A violation of physical privacy. I've seen that in my care. Threatening to withhold treatment or coercion. I've seen that in practice as well. So this was really grounding for us to know what is our current reality. I think many of us could speculate on what our current reality is, but it was good to have data to support it. And I want to share a couple of direct quotes, because I think there's nothing more impactful than the voice of the patient and the birthing people that we care for. So the first direct quote that I want to share with you, it says, "I was told I was hurting my children and being selfish because I wanted to have a vaginal delivery. Both children were head down. I was forced," look at her words, "forced into a cesarean section by my OB." So the next quote says, direct quote from a client, "the forced episiotomy. The doctor didn't care, refused to give me medication because my episiotomy hurt. The nurse from this institution told me, get over it, and gave me lube and told me to have anal sex instead." That's the care we're getting in Southern California if you're not insured and if you rely on medical insurance. And this is a Hispanic woman in California. And the last one that I'm going to share with you, again, just to ground us on why this work is important. When I refused to be induced, even after I was a couple of days overdue, I seriously started to feel like I was the problem. And it was a horrible feeling. And this is a white woman who gave birth in Iowa. So we really have great information to illustrate to us the need to focus on what respectful maternity care would look like. We already know that experts agree that it impacts the birthing person, their family, and the community. But we needed to hear it in their own voice. So in the next slide, and this was discussed so beautifully, but I just want to highlight that we know that there's significant disparities as it relates to morbidity and mortality, that Black and brown women who look like me, I like to say, are 3 to 4 times in some locations around the country, 7 to 8 times more likely to die than any other races. And what we know is it doesn't matter about education, because I remember hearing early on there's this perception that Black patients don't have access, they're uneducated, that they're young, and that they're uninsured. But the truth of the matter is, regardless of our education, our income, our zip code, our insurance status, we are vulnerable just by virtue of the color of our skin. And Dr. Joya Creer-Perry was the first person that I heard say, it is not race. And Dr. Meadows said this as well. It's not race that makes us at risk, it's the racism that we are facing. So the last supporting slide that I want to share with you from 2006, and I love it so much, and I think it's still very timely today. And that's a direct quote, if you go to the next slide for us. It's a direct quote from Mahmoud Fatala, 2006, and he said, "Women are not dying because of diseases we cannot treat. They are dying because society has yet to make the decision that their lives, my life, is worth saving." And in this post-Roe era that we live in, I have to agree, because we know that we were already struggling with morbidity and mortality in the maternal space. And now as we are limiting access to birth control and access to safe abortions, we are making it even more unsafe for all women. So this is our grounding information. Let me introduce you to aspects of the Respectful Maternity Care product that AWHONN developed. And we launched this just January of this year. So it is brand new and we're super excited about it. And the work took a little over 2 years. We started with a framework, and I'm going to share the framework with you. And the framework really informed everything else that we did, right? So the framework, and then the evidence-based guidelines, and then last but not least, we created the toolkit. So I'm sure you guys are ready to get started. I'm excited to start with you. So let's look at the framework. And I think this was beautifully designed. And what's important to note with the framework is that we understand that there's competing influences that converge over the patient-provider interaction. So there's the patient, what the patient brings to the relationship, and then there's a care team, right? So let's start with the patient. We know that the patient has an expectation as it relates to pregnancy, labor, and birth. This is something that they've been thinking about usually for years, and they have a vision about that. They have lived experience. Their culture plays a role on this. And then absolutely their knowledge of the healthcare system, or even lack of knowledge of the healthcare system, and self-determination. That's an influence in the interaction, patient-provider interaction. And then you have the care team. What do we have? We have our organizational culture. So we have culture, and then we have policies, two different things, right? Policies are what's written, what most of us are aware of, and how many of us abide by. But the organizational culture, that's the unwritten, the rules and the beliefs and the things that we say, right? So that influences. And then resource allocation and constraints, that definitely plays a role. You know, I give the example of not having enough Novi. And Novi is what one of the monitors we use from GE, and I think Philips has one too. But it's wireless monitoring that allows our patients to ambulate. So let's say we only have 5 on your labor and delivery unit, and the 6th patient walks in and she wants an unmedicated birth and she wants to be able to ambulate. If you don't have that, that has an impact on her care. Or let's go to the NICU and say you only have 10 giraffes for your NICU, and that's the wonderful incubator warmer system that we use here. And you're planning for a 21 4/7 week birth. So now you have to look at all of the babies that are in the existence giraffes and decide, gee, are any of them able to be graduated to an open crib or to another bed? So that has an impact on the decisions that we make as it relates to the care for patient. And then there's professional training, and then our lived experience. Again, those two converge on our ability to provide basic human rights. That's what you're looking at in the blue circles. Basic human rights, which starts with freedom from harm, autonomy, dignity and respect, accountability, and the provision of informed consent. Again, informed consent, I feel like that's a whole other conversation that we can have for an hour. As you look at the blue circles, you see that bias gets in the way. And we need to recognize that bias exists. And we need to recognize when it shows up so that we can mitigate it. So that is a framework. And again, it informed everything that we did. In the next slide, you'll see that the team that worked on the evidence-based guidelines, they landed on these 6 elements. If you go to the next slide for me, they landed on these 6 elements of the guideline. The team that did the research and the literature review, it was a lot of work. 15 months, they came up with the evidence-based guidelines. And we do not have time to go into all 6 of the elements, but I want to speak to all of them because they're all super, super important. So element 1 is awareness. When we think of awareness, I want you to think, just this morning as I was reviewing my slide, I went to throwback song, Michael Jackson back in the day. I'm starting with the man in the mirror. So awareness is about us. We're the man, the woman, the person in the mirror, right? It's about being aware of how we show up in relationships and in interactions with our patients. In awareness, it's imperative that we recognize our bias. My team, when we first started our journey towards equity, we started with the IAT, the implicit associate test. And it was important for us, for everyone to do the survey on race, because we needed to be able to recognize, acknowledge, and own our bias. A spoiler alert, we all have bias, all of us. Bias is neither good nor bad. It just is, right? It's based on your lived experience, where you grew up, how you were parented, where you went to school. It is part of who you are. If people tell you to eradicate your bias, you can't. It's part of who you are. What's important, though, is for you to be aware of your bias and recognize it when it shows up, and make sure you are able to say, yeah, this doesn't belong here in this conversation. So we started with awareness, and then we went to mutual respect. We were intentional in saying that it's mutual respect. It is part of the nurse's code of ethics that we show up in our interactions with patients with compassion and respect. So that's part of the ANA code of ethics. But we want it to be mutual because we recognize and understand that the climate in healthcare, in our hospitals right now, there's a heightened level of incivility, of disrespect from sometimes patients, sometimes families. So it's really important that we have that mutual respect. We are first, as healthcare providers, responsible for us, right? So I enter into every conversation with respect. And I also share with the patient that we appreciate respect on their end. Then we go to shared decision-making. What's important in shared decision-making is that we need to really eradicate the hierarchy that we've created in healthcare, which says that the provider is at the top and the provider is the best person to make decisions for patients. That is so not true. In shared decision-making, it's important for us to really amplify the voice of the patient. What's important to the patient? What have they been envisioning about this pregnancy, labor, birth, postpartum period for years and years and years? A normal conversation that I have heard over the years is a provider comes in and says, okay, it's time to break your water. Shared decision-making is coming in and having a conversation with the patient and say, I think now would be a great time to break your water, rupture your membranes, and let me tell you why. And then after we have that conversation, ask the patient for consent. Do you agree? It's really transforming how we engage with patients and making sure that we're allowing the patient to have a voice and have a say in this conversation. I'll tell you, I had a call from a patient. I think she complained to the lactation consultant who sent out an email to her leader, who sent an email to me and said, ooh, I think somebody needs to go visit this patient. And she said, Rose, do you want me to do it or do you want to do it? I'm like, no, I'll take this one. And in speaking with that patient, she was really clear that she felt coerced to have her membranes ruptured. And that when she said, no, thank you, that the conversation did not go the way that she wanted. And it was really important for me to engage with her and listen to her and validate what she was saying was important. And then having the conversation with the providers and hearing what the provider thought and said, well, this is what she thought, this is what the patient thought, and how do we ensure that we don't have these kind of miscommunication in the future. So shared decision-making is important, and it goes right into autonomy, right? Or agency. And when patients come into our setting, the first thing we do is we kind of rip all autonomy from them. We take their clothes off and take their belongings. And it's important for us to recognize autonomy. Is it the worst thing in the world if the patient wants to labor with a gown that they brought to the hospital for labor? I don't think so. Nor do I think it's necessary going to culture, nor do I think it's necessary to say things like it's going to get very dirty. I bet the patient knows it's going to get very dirty, right? They gave it some thought. How do we hold autonomy for patient? Autonomy and dignity go together because we need to protect their privacy, to ensure that we knock before we come in, that we introduce ourselves, that we ask the patient, how do you want me to address you? What is the name that you want me to call you? All of that is autonomy and dignity. And then last but not least, and accountability is my favorite. If you ask anyone in my leadership team, what's Rose's favorite word? They will tell you accountability. I love accountability because I don't think any new initiative is successful without accountability. And we wove it in, and it's accountability by way of use of the data to hold ourselves accountable. If we say we're going to make this change and our data should change this way, and then we look at the data, there's no change. We need some accountability. But it's also centered around behavior. So if you say you want to implement respectful maternity care, and if somebody behaves in a way that's counter to respectful maternity care, what happens? Are there any consequences? And if there's no consequences, then don't bother implementing, right? We need to ensure that we create accountability. In the next slide, James Baldwin, is one of my favorite quotes. We know that not everything can be changed that we face, right? But definitely nothing's gonna change until we face it. And I'm super proud of the team in Massachusetts and Pinquin. You guys are facing it head on, and you've created beautiful accountability measures, and you're having great success because you've done that. So again, it was important for us at AWHONN. We wanted the change, and we said we're going to start the change by, first of all, facing the fact that we have a problem and that we can be part of the solution, and putting a solution in place that I think that we are really proud of. So in the next slide, we're going to talk about the toolkit. I really, really love the toolkit. I love the entire product, if truth be told. But I love the toolkit because that was my group. I had a chance to really be intimately involved in the creation of the toolkit. And again, we're informed by the framework. We were informed by the evidence-based guidelines, which was substantive. We reviewed all of that, and then our job was to create the toolkit. A couple of things we thought of as we were planning to create the toolkit. We know we are a nursing association, right? So our members are nurses, and we know that 10 steps would resonate with nurses because there's the 10 steps to baby-friendly or successful breastfeeding. So right off the bat, we said, let's make it 10 steps. We're like, yes, that's a great idea. Let's make it 10 steps. And then we said, let's create an acronym, because in healthcare, who doesn't like a good acronym? We all love a good acronym. So you'll see that the acronym is CARE Path. And CARE is really at the heart of all we do in healthcare, hence the term healthcare, right? Physicians, midwives, nurses, doulas, lactation consultants, all of us, we care. So we said, we'll create the CARE Path. And we know that nurses are intrinsically care, and here's the path towards respectful maternity care. So that's where the acronym came from, and that's where the 10 steps came from. So I'm going to go ahead and chat with you about the 10 steps. So step number 1 is confirm commitment. Ideally, it is perfect if the commitment comes from a decision maker, like someone in the C-suite. We want someone from the C-suite, not because they have greater value than anyone else, but because they have greater access to resource than others, right? So C-suite is ideal because they can write the check that goes with the initiative we want to put in place, but it doesn't have to be the C-suite. Let me tell you, I'll tell you more about our journey towards equity a little later, but it started with me as a service line leader. But we said, confirm commitment. Before you start anything, you have to have commitment. I think about it, one of the analogies that I give is about weight loss. Weight loss, I'm always thinking about weight loss. That's just the woman, the mom in me. So before we lose weight, you have to first decide you need to lose weight, right? Step number one, I need to lose weight. This is how much I need to lose. And then step number two to the care path is to assemble a team. It is super helpful to have people on the team that are excited and passionate about appropriate care for our patients. So assemble the team. And then step number three is readiness. And in that step, we're data warehousing on the site that holds a Respectful Maternity Care Toolkit. So we have lots of assessments on that for step number three, because if you're not ready, then don't do it. Let's go back to weight loss. It's like I made a commitment. Okay, I need to lose 12 pounds by this date. Am I ready? Well, let me look at my calendar. I'm traveling a lot in the next 6 weeks. And when I travel, I don't eat that well. So maybe now is not the best time, right? So we need to do the readiness assessment to get a good feel for what is your organizational culture, and is this a change that we can do at this time? Step number four is educate all. And we borrow that right from Baby Friendly. And we need to educate all. Let me tell you, I think in my second Biden stakeholder meeting, when a woman spoke about her birth experience, and it wasn't even about birth. She said, when she went in for an ultrasound, she and her husband, this is a Black woman, mid-30s, articulate, well-educated, affluent. She went in for her ultrasound, and her husband was with her. And she talked about the sonographer asking her if this is her first child. And she said, yes, it's my first child. And then she asked her again, well, are you sure? She was like, yes, I'm sure it's my first child. And she looked at her husband and said, I'm sure it's not your first child. And she was like, this is our first child. That's how her experience went. She went on to say that she and her husband were so excited at the ultrasound and to get to hear the baby's heartbeat, and they're going to do measures. And the sonographer said, I don't know why you're so excited. She really trivialized the experience for her. And when I heard that, I'm like, yes, everybody who touches the patient needs to be educated. So it's not just the providers, it's not just the nurses in my service line, it's not just the techs. We invited food and nutrition, we invited registration, we invited environmental services. Everyone who touches a patient needs to be educated on respectful maternity care. And then step number five is to propose a policy. We write a policy because it's important enough to do all this work. It's important enough to develop a policy. And then adapt the culture. This is very, very important. Adapt the culture. What are the things that we permit in our culture to be said, to be done, that needs to no longer be said or be done? I give the example of patients coming in with a birth plan. How do we act? We react when a patient comes in with a birth plan. Are we like silently rolling our eyes? Are we saying, oh, she's going to go right into the OR? That's part of the culture that needs to be shifted. Even if we're not saying it or rolling our eyes, that energy does not need to be in the space of that family, right? Making fun or trivializing people's names. I've heard this more times than I can number. Somebody runs into the nurse's station. Oh my gosh, y'all, let me tell you what the patient in room 7 decided to name her baby. And then everybody burst out laughing. That's the epitome of disrespect. And we need to be that granular when we think about our culture in making those cultural changes. Step number 8 is accountability. We've talked about that. Step number 7 is accountability. 8 and 9 is talking about data management. And I have a slide, and I'll talk to you a little bit more about that, and then have a celebration. These are the 10 steps. If you go to the next slide, when you go on the AWHONN site, this is what a step will look like. Each step starts with a video. just talking about what's involved in this step. And then there's a little paragraph that describes the step. And then you'll see in the blue, those are all hyperlinks to resources. Again, we didn't create everything. There's a lot of great work already out there. We partnered with so many people to say, hey, can we please include your work with ours? This is going to be enduring work and it's always going to be updated. So that's what the step looks like. We also believed, if you look at the next slide, that as organizations were going on this journey towards equity, that they may need some additional resources. I know that I shared a lot of articles that we use. We do a lot of journal article reviews at my organization through our journey towards equity. I shared that, and we did a fairly extensive lit review to find other great articles to start the conversation about what does equity look like, and how do you move towards equity. We have SBARs on the AWHONN Equity site. We have amazing videos and presentations from wonderful speakers, and we have webinars. All those are resources that we wanted to make sure that was available for our members. And in the next slide, this is something that I contributed from my organization. So we created a disparity dashboard in September of 2020 in our organization. We knew that there was a lot of data that we were already collecting for Joint Commission, Leapfrog, CMS, and all others. We're like, okay, let's look at this information, but let's stratify it by race. We have already been collecting it. So when we did this deep dive, and these are the metrics that we looked at overall C-section, induction rate, exclusive breastfeeding, hypertension, blood sugar monitoring, and this is for the mom or the birthing person. And then we had 2 neonatal ones. We looked at low birth weight and preterm birth. So as we looked at this, we were surprised. I think surprise is a good word. We were surprised and in some places really shocked by the disparity of data. Because as you look at aggregate data, it tells you one story, but disaggregated data tells you the truth. So be ready for the truth and be ready to be surprised. So as we looked at our data, we decided to focus on one thing. We were thinking about low-hanging fruit. What is the area that we can have the quick win? What is the area that's within our locus of control as it relates to the hospital? So we said breastfeeding. We are all over that, breastfeeding. When we started with breastfeeding, we had exclusive breastfeeding rate. And what we quickly realized, because as we shared data with our team, we heard a lot of, excuses. I'm going to use the word excuses. We heard a lot of excuses as why the data was so disparate between our Black patients, Latinx patients, white patients, and Asian patients. And what our own staff was saying, it's about the culture, Black women don't want to breastfeed. It's about education. They don't know the value of breastfeeding. So many excuses. So we changed our metric. So we made the denominator, we changed it to all patients who on admission said that they wanted to breastfeed. So we take out the culture, we take out the education, we took out all the variables. Only the patients who had made the decision on admission to the hospital that they were going to breastfeed. And then when we started looking at that data, and there was still a lot of disparate data, we had to recognize, we had to own that we were part of the problem. That wasn't easy, but it was necessary. So that's, and when we talk about the data management and to test measures, that's what I mean by that. Being able to do a deeper dive to say, okay, am I contributing harm? There's usually no intentionality to contribute harm, but sometimes harm exists. And unless we're willing to peel back the layers of the stinky onion and own it, then we're not going to have true change. So in the next slide, this is just my personal journey in 2017. I love that you guys started in 2016. In 2017, I coined the hashtag not on my watch because, and this is 2017, y'all, I was done. I was through with the rising rates of morbidity and mortality. I'm like, seriously, y'all? I'm sick of this. I'm over it. I'm like, what can I do? And I'm like, okay, not on my watch. And I remember when I shared my hashtag with my leadership team, I'm like, this is going to go viral. Even if it means going viral is just within our organization, it's going to go viral. And it has really gone a little bit viral in healthcare, and I love it. And I created this as a call to action for nurses. I'm a nurse. I speak the nurse language. I said, y'all, if nurses, the largest contingent in healthcare, would join arms with me and say, not on my watch, what does that mean? That means that with every interaction with our patients, we say, I'm going to treat you with dignity and respect. I'm going to listen to you and believe you. I'm going to amplify your voice. I'm going to use evidence-based care. I'm going to advocate for you. I see you. I'm your person. I thought in 2017, and I still believe it today in 2022, that if we get behind that concept, that we will mitigate morbidity and mortality. So we ended the toolkit with 6 commitment statements, and that's what you're going to see next. Because we know using the concept of appreciative inquiry, that the words we use creates our reality, that asking certain questions really instills joy and hope, and that images are transformative. We said, let's come up with these commitment statements. Again, the words we use creates our reality. So to provide respectful maternity care, I commit to shared decision-making. I commit to listening with empathy, not only to respond, but to understand. I commit to treating you with dignity and respect. I commit to speaking up for and advocating for marginalized people and communities. I commit to advocating for you. I commit to evidence-based care. And whenever I ask around after I do a presentation, is there anything in these commitment statements that you can't get behind? Everybody always says no. We can totally get behind this. So this is a commitment statement that came out of the work that we did at AWHONN. And I know we've been sharing resources, but in the next slide, there is a QR code. So if anyone did not get the link that I think was dropped earlier, you can go ahead and use your phone and get the QR code. And the next slide is simply our references. So, and this is not all inclusive, but it's a good bit of references. So I know that's important for some researchers. So if you want to take a picture of that, that's available for you as well. And then I end with just a final slide about how to find me if anyone is looking for me. This is a way for you to find me. Again, thank you. I was super excited to speak for you. I didn't expect to be inspired as well, and I am inspired by the work you're doing in Massachusetts. So incredibly proud. It really fuels my desire to continue on in this work, to know that we can have that level of success. We're doing great work, but we know that we have far to go here at Emory Decatur Hospital, and definitely in the state of Georgia. I tell folks that I hate that the March of Dimes grades that we get in the state of Georgia are so terrible. Like, I think the year that I moved here, it was F, and then we went to a D. We're not a D organization at Emory Decatur Hospital. I'm so happy to say that. But I want all of Georgia to be the most healthy state as Massachusetts, as you guys are. And I want our outcomes to be stellar. So to that end, I continue in this work. But thank you for the opportunity to speak. And I think my time is up. So I'm gonna turn it over to Dr. Meadows.
Thank you so very much. This was fantastic. We are all certainly inspired, and really, really fabulous talk. So many great accolades coming in the chat. For those of you who have questions, please put your questions in the chat if you have, and I'll watch for those for just a moment. I do have a question while we're waiting to see if there are others. And so Rose, thank you so much for all you've done and for all you do, and for the hashtag not on my watch. We'll continue to use that. I think that's a really great phrase to use, especially when people are thinking about phrases they can use to speak up. That said, in terms of having this data dashboard, this racial disparities dashboard, how have you guys implemented utilization so that it's visible to others and palpable to others that you're doing this work at Emory Decatur?
Yeah, that's a really great question. And we started a perinatal equity council about a year ago. And in our perinatal equity council meeting just yesterday, we were talking about our data. So we did a couple of things. Number one, data visibility was very important to us. And we have data on a weekly basis that we put on our huddle boards. We have tiered huddles starting at 7. We have 5 of them a day. I'm sure you guys are huddling also. So data visibility was very important for us. We share it at our huddles. We share it monthly at our staff meetings, department staff meetings, and also our OB quality and safety meeting. We share the information there. On a quarterly basis, we share it also at our OBGYN department meetings. So we share that information that way. We started by sharing the data. It was blinded. And then I said, hey, we need to be transparent with our data. And then the data was unblinded. We slowly socialized the team to the concept of data transparency. And that really started it for us, just the visibility and the data transparency. And as we looked at breastfeeding, we made changes. We were constantly making changes because we have data on a weekly basis. And the last data that we shared yesterday, to see our data looked a lot like one of the earlier slides you showed with a huge disparity. And now our data is almost nearly equitable. I told them that a member of my team, she texted me that slide. I was traveling, I was in the plane, and just before I turned it off and I saw that slide and my eyes filled with tears, I was like, oh my gosh, we're really doing this. It's almost equitable. So we were very intentional, but visibility, accountability, we also created a couple of things to get ownership for our nurses. We decided to find breastfeeding champions. We would award folks who had the best rates. And everything that we did was a point in our graph to see what kind of movement that we had, and we just remained consistent with that. So those are all of the things that we did to help.
That is fantastic. Congratulations on that. It just shows how this is actionable and this does work. With that, there was a question in the chat that asked if you have considered or have you added patient satisfaction metrics to your dashboards?
Yes, we have. That's a great question. Our dashboard is like very complex now. We added language because we are in DeKalb County. Right next to us is Clayton County, which is a refugee county, and we have over 41 languages here at our hospital. So we felt it was important for us to add language as a metric, not just race. And then we added patient satisfaction. We added patient satisfaction, and we also added communication with nurses. We were a little granular. So overall patient satisfaction, and then 3 other metrics that we look at under patient satisfaction: likelihood to recommend, communication with nurses, and transition of care. We don't do transition of care as much in our service line. But all of that is part of it. And yes, we're looking at all of that. And I will tell you that our patient satisfaction scores is the highest it's been in over a decade in the past 2 years during a pandemic. So you cannot tell me that our intentionality and the education that we put in place, we created a respectful, equitable care class that we taught in 2018. In 2019, we did AHRQ's shared decision-making. And then we did a class on unique families to cover the LGBTQIA+ and surrogacy and adoption. We did a lot of things to prepare us, and you cannot tell me that it didn't work, because during a pandemic where we're struggling with staffing and it's really hard out there, our patient satisfaction is the best that it's been. So intentionality pays off. And yes, we are measuring all of that.
Thank you so much. That is terrific. Well, congratulations to your team and all you've done and accomplished, and particularly the families in Georgia and beyond that are benefiting from all that you've done. Well, thank you so much. And so without further ado, I'll move the presentation forward to Kaylee to talk a little bit about the participation logistics. I do want to say for others, we will definitely invite Rose Horton and her team back. Hopefully we'd be able to have them join us again at our spring summit to talk a little bit more about their data dashboard and what they've been able to accomplish and support their staff with that. So we'll turn the spotlight over to Kaylee.
All right. Thank you, Dr. Meadows, and thank you, Rose, for that wonderful presentation. And thank you to Drs. Jop and Kristen Price as well for grounding us in equity and data and respectful care. And so now for a few minutes, I'm going to walk through how we're going to put all of these things into practice here in Massachusetts. Just a couple of reminders, if you have any additional questions for Rose, please put them in the chat. And also keep an eye on a chat because one of our wonderful med students helping us today, Claire, is going to be putting links into the chat as I'm speaking. And so that'll be the quickest, easiest ways to access some of the things I'm going to talk about. So the first and one of the most important steps to implementing this maternal equity bundle in Massachusetts is assembling your team. Now we have a form on our website. It's a team roster onboarding form, and this will tell me who at your hospital should be receiving information about the webinars, should be receiving resources that we send out for the bundle, important information about data submission. So anybody working at your hospital on this bundle should be included on your team roster that you submit through our website. So Claire will be popping the link to this form in the chat. And then you'll see some overlap, I think, between the AWHONN Respectful Care care path and the things I'm talking about today. So we also have a team readiness assessment that Claire will put in the chat. And this assessment is we've done this with bundles in the past. The Penguin team does look at it just to kind of see, at what, where everybody is coming from as we begin this bundle, just in terms of capacity, resources, enthusiasm at your hospital. But we also encourage you to use it as sort of an internal tool to just assess where your team is as we prepare to launch this work. What are your strengths? What are your weaknesses? What are some areas that you need to keep an eye on and give more support to as we go through this 12-month long implementation? So it's a really brief assessment, 10, 11 questions. We encourage you to do that. And now we get to the data. So for those of you who have done a bundle with us before, you know that we have a AIM monthly survey that we send out on the first of the month. And this is where teams submit the structure, process, and outcome measures related to the AIM bundles. So like I said, submission starts on the first of the month and it ends on the 10th. And then the exciting part about this survey is our wonderful partners at the Betsy Lehman Center for Patient Safety will then analyze the data you submit in aggregate, and then we'll be able to see the progression of data over time, because we'll present that aggregate data on our monthly webinars. So we'll be able to see, metrics grow and improve over time. And just a note that on the monthly webinars, no hospitals will be identified. It's all presented in aggregate. So we'll get to see as a state how we're improving. So this survey not only assesses structure and process measures related to maternal equity, our current bundle, but if you participated in the hypertension, hemorrhage, or opioid use disorder bundles, you can still continue to submit data for that as well by clicking the check boxes on the first page of the survey. And the link to the survey is sent to who you identify in your team roster as your OB champion or your RN champion. Or if neither of those people have the capacity to submit data, we also see QI staff submitting data, or OB educators, whoever is able to have access to this data and submit it in a timely fashion, that will be your person that we can put on the listserv for the red cap. taking a bit of a bigger step back, just to outline what our data flow is like. So hospitals receive this AIM monthly survey link that has outcome, structure, and process measures, or sorry, mostly structure and process measures for each bundle. Hospitals complete that. It's sent via REDCap to the Betsy Lehman Center and to Pinquin. And then we report that data back to you on our monthly surveys. And we also are trying, or we will prioritize developing individual reports of AIM data for hospitals moving forward. We know that's something that we've wanted to do for a long time and haven't quite had the capacity, but that is in our sights. So hoping to get that to you soon. Now, one key thing that I want to point out about this graphic is the link between hospitals and Betsy Lehman Center is a document, a memorandum of understanding for data sharing. That's what allows hospitals to submit to Betsy Lehman Center. I won't read all of this, but this MOU just essentially outlines the responsibilities of BLC, of hospitals, of Pinquin, to collect your data, protect your data, analyze your data. Our purpose of collecting this data is always quality improvement. We want to keep your information safe, and we also want to use it to help you. Almost 30 hospitals out of the 40 in Massachusetts have already signed this MOU. So if you're not sure whether your hospital has signed it yet to participate in the equity bundle, just send me an email and I can let you know where you stand on that. So we'd love to get those last 10 hospitals on board for the equity bundle and submitting AIM data for us. So this is another wordy slide. I won't go into it completely, but these are the equity bundle measures that we will be collecting monthly. Structure measures ask about establishing a formal equity team, communicating your equity team's goals for the bundle to faculty and staff, developing goals, change statements, an anti-racism statement for your department. We'll ask about collecting and stratifying data by race and ethnicity, and whether your hospital has implemented a patient-reported experience measure or PREM. More on PREMs later if you have not yet done that. And then process measures, we'll be asking about rates of staff education on bias and respectful care, like Dr. Measures or Dr. Meadows mentioned earlier. We are pulling hypertension and hemorrhage still into this bundle, so we'll be asking about timely treatment, hemorrhage risk assessment, and QBL. And so just a heads up about process measures, we will be asking teams to do chart review by race and ethnicity. So that might be a bit more of a timely process. So we encourage you, if you have any concerns about that in particular, to reach out to us and we'll provide as much support as we can. Just one new note about the structure measures. For those who've been submitting AIM data with us before, the AIM national program starting October 1st is transferring to a new structure measure Likert scale. So previously we had you answer structure measures. There were 3 options. You could select, a structure has not been started, it's in progress, or it's fully in place. So AIM has lengthened this Likert scale into 5 points now. Beginning with 1 not started up to 5 fully in place. AIM purposely left the middle values of 2, 3, and 4 undefined, just so that hospital teams can determine where you feel you fall between those outer parameters. But we did receive some feedback when we initially reviewed this new structure that some examples of what those middle values could be would be helpful. So this is a slide here with a few examples, and we will be making sort of an addendum available, an appendix, with these examples in it, so you can refer to those when submitting data. But I'll go through the first one. So structure measure 1, does your hospital have a formal equity team in place? So the example of a 1 could be, So you have a team and it's based, and it includes diversity of roles. So a 1 for that could represent that you don't have this equity team yet in place, and there's no diversity of roles. Basically, nothing has been done in that area yet. A 3 could suggest there's some diversity of roles on the team, but you could have more. And then an example of a 5 is your team includes folks with many different types of roles, MDs, RNs, CNMs, social workers, etc. So again, we will be sharing an appendix with more examples of what all these values could mean for the new Likert scale until we get a good feel for it. This is just a couple of screenshots to show you what the survey looks like in REDCap. So this is a picture of the process measure section. Again, we will be asking about education in sort of these 10% increments. And then an example of a chart review question. Here's what it looks like for hypertension. I just want to point out that we've gotten this feedback before that chart review can be a really big lift, especially when there are other demands on time and staffing. And so to make this a little bit easier, we're offering the opportunity to just take a sample of charts. So if you had 10 or fewer births for the population that we're asking you to chart review for, we're asked that you review all 10 of those. But if you had more than 10 in that population you're reviewing, you can take a random sample, and we include instructions for how to do that. And as always, when it comes to data, no question is too small. You can always send me an email, and I'm in very close communication with the Betsy Lehman Center. So we'll help you sort out any issues with the survey or any questions you may have about data collection, especially since these equity bundle measures are very new. And we are accepting feedback on the measures as well, because they're ones that we've kind of developed from the ground up. So that's data. That's a big piece. I'm almost finished. So the other piece of this is we will continue to have a monthly webinar series for the equity bundle. This is a list of our dates and our topics that we're so excited to develop further for you and see you online every month for. We're sticking with our usual schedule. The webinars are on the third Tuesdays from 12 to 1 Eastern time. And we're really excited because we've paired a webinar with each of our data measures. So there will be a webinar on each of the structure measures, on each of the process measures. And so we hope that that extra bit of support and education will just help make answering those measure questions even easier over time. And like we've said kind of throughout this kickoff, our webinars are always recorded and posted with slides on our website. And myself and our student team are working to obtain accreditation for these webinars as well. So we'll soon be offering CME, CEU, and social work credits for attending the webinars live or by watching the recordings. So one of the last things I'll say is, so we've had a landing page, a home page for each of our AIM bundles. We do have one for the maternal equity bundle. Clara will be putting the link in the chat. So here is where you will find when we say, oh, we're going to post it to our website, this is where it's going. So we'll have all of the resources, all of the webinar recordings, QI resources, anything related to this bundle will be on this webpage. And we have this special page devoted to resources. So this is where we'll be posting things, referenced in the webinars. I can tell you that the link to the AWHONN Respectful Care Toolkit will be going on here shortly. Claire and I were messaging about that earlier. And if you have any, if you see any gaps in this resource page, or you have anything that you want to send us that you want to share widely with teams, please send us an email. We'd love to include it. So just to summarize, this is sort of the participation logistics checklist for the equity bundle. Clara will be putting the links in the chat one more time. So you complete your equity bundle team roster. complete the equity bundle readiness assessment. If your hospital still needs to sign a memorandum of understanding for data sharing with Betsy Lehman, you'll need to complete that. The first REDCap survey for the equity bundle measures will be sent out October 1st, and you'll be completing that with data from September, and that will serve as baseline data for this bundle. I didn't go into this too much today, but sort of what we've spoken about in other bundles and what will be encouraged for this one as well is creating an aim statement and a driver diagram for your equity bundle work at your hospital. We have resources for both of those. And Claire and I are actually developing a QI Basics video series to help go into some of these more core concepts if you need a little bit of extra support there. We have the Equity Bundle monthly webinar series on the 3rd Tuesdays. We'll be sending out a link after this kickoff for how to register for that. And then you submit monthly data to REDCap, and then you reach out to us at any time. We can do coaching calls, we can answer questions over email. We are here to support you the whole way, and we're so excited to be bringing this bundle to you after many years and hours and many people on our teams devoting time and energy and knowledge to this. So thank you all so much, and let me know if you have any questions.
Thank you so much, Kaylee. That was really thorough. And thank you, Kaylee, for all you do as a project manager. The Pinquin, the heart and blood and pumps and flows through all that you get accomplished for us. So really appreciate that. So for those of you who have questions, please add any questions you may have to the chat. We'd love to help be supportive and helpful with any logistics to move you forward in this endeavor. And if those of you are interested to joining the advisory board, please let us know. We know there's 4 minutes left in our hour and a half presentation. And so at this time, we'll take any additional questions and then also get ready to close out. Laura added, I'm curious to know what percentage of sites will be continuing to submit data on hem hypertension versus shifting resources to this bundle. I'm hoping, Laura, we can let others comment on that, and we can even ask that question. I'm hoping that those who are continuing doing work with hemorrhage and hypertension, the process measures for hemorrhage and hypertension are within this bundle. The structure measures, though, are the ones that would be in a different, that are a bit different. And so with that being said, if you're continuing work on hemorrhage and hypertension, you can continue your work through looking at it with the equity bundle as well from a process standpoint.
Yeah.
I also want to invite, go ahead.
Sorry. I just wanted to say too, we accept any data for any bundle at any time. It all just kind of depends on your staff capacity. So if you feel like all you can take on is equity, data submission right now, that's perfectly fine. But if you, did hemorrhage, hypertension, OUD with us and would like to keep sharing your data with us to those bundles specifically, we'll take it. There's really, we'll take it all is what I'll say.
BLC, thank you so much to the Betsy Lehman Center for all they've done as our data center. They continue to allow that, as Kaylee said, the REDCap surveys to be a resource for you so that that data can be collected and then you can go back to access your data as well. So for individual teams who want to use the resource in that way, it continues to be that.
Yeah. I'll also say too, really quickly, I'm already receiving some emails asking for a copy of the PDF of the REDCap survey. So if you'd like to take a look and review all the measures before the link comes out on October 1st, shoot me an email and I'm happy to share that with you.
Terrific. We'll go to the next slide. We're waiting for additional questions. And want to also invite anybody from the leadership team of Pinquin to add any commentary that you think may have been missed. But we have upcoming events. Our first webinar is going to be the discussion of a practical PREMS, to the question that was asked of Rose earlier. Do you have patient-reported experience measures in their dashboard? And we will be talking about implementation of patient-reported experience measures that look at dignity and respectful care. The Madam and Maury surveys that were established by the Birth Lab and Dr. Badam's group that was shown on the slide, one of the earlier slides. The Madam version of that is incorporated into the survey for patients for sites that implement team birth. So we'll have our team birth colleagues come and present with us and show what they do on labor units to elevate and increase respectful care. And also it is a way to implement a practical PREMS for your site team. And so we want to have them as a resource. They have 10 hospital teams working with them, and we're really excited for the Massachusetts hospitals moving their work forward with team birth. We also have the Massachusetts Speak Up Champions Implicit and Explicit Bias Education from PQI. That will be on December 7th and 14th from 8 to noon on both days. This is virtual. Of course, the education is free. Thank you to the Massachusetts Department of Public Health and Dr. Jop for continuing to support and bring that education to our colleagues. Next slide. Just want to make sure that everyone understands that as we go through this bundle, we're all going to be taking opportunities, having opportunities to take action to advance equity in maternal and infant care. Everyone's on differing journeys of their, different stages of their equity journey. We want to bring each other together and help each other along the way. Everyone's in different stages of their data infrastructure and bringing us further and closer to data dashboards that allow us to do the kind of work that we're talking about. We want to help each other along the way. And everyone is in different places with their level of community engagement. It's something that's really important and integral to the work we're trying to accomplish. And so you'll be hearing more about that as we move through these webinars. Next slide. And as many of you have all seen, our House of Maternal Care and Birth Outcomes. This is an ode to the book Cast by Isabel Wilkerson. When you see the house to the left, this is the House of Maternal Care and Outcomes, given the data that we've seen from our state, from the CDC. We know that we have inherited this house. We were not here when it was built, but we are heir to whatever is right or wrong with this system. And all of us in our own transformational spaces, whether we're in administration, whether we're physicians, whether we're nurses, whether we're in midwifery care, no matter what, social work, Department of Public Health, doula care, patient navigators. I don't want to leave anyone out, but for anyone that hasn't heard their specialty, just know you too. All of us have our own transformational spaces that we could work within to really transform this house of maternal care and birth outcomes. Because without investing and engaging in the work that needs to be done, we won't be able to realize the vision toward the right, which I know we can get to. Next slide. And so with that, we just want to close and acknowledge all of you for joining. Thank you so much to everyone who's joined. Thank you to the California Maternal Quality Care Collaborative for their work and inspiration in birth equity. ILPQC, the Illinois Perinatal Quality Collaborative, also has a birth equity initiative that they've engaged in. ACOG District 2 and IHI, thank you for all of those partners that have supported us in this work. And with that, I see no additional questions in the chat, but we want to send a special thank you to those of us, our large community, that we've been serving and working together as partners. We've waited long enough for this particular bundle and for this change. And so thank you for being a part of us kicking this off and moving this work forward over the next year. So excited to be here with you and to be hand in hand and join together for this. Thanks so much.